So I want to talk broadly about anti-racist praxis and public health research. My background is my master's is in bioethics and humanities. My PhD is in health behavior, School of Public Health, and what I was able to really gain through the Institute was the integration of both public health and bioethics in a research context. So today I'll talk a little bit about my journey to empirical research ethics and some of the things that I've been able to learn and leverage through the Institute and to really use to promote and advance my research program that's really focused on advancing health equity. So I'm in a school of medicine now. I teach medical students, mostly clinical ethics, bioethics, and I'm now teaching some health policy courses. So I always just start off talking about my experience, my dissertation research, working with women living with HIV, Black women, and the Deep South, and I really just sought to understand women's experiences living with HIV. So at the time, my interest was very much on reproductive and sexual health, but I wanted to understand how women were navigating these decisions, how were they engaging with healthcare around pregnancy intentions and pregnancy decision making. So just to give you a context of 42 women living with HIV, I conducted all of these interviews, and this is just a snapshot of some of the things that I learned. Again, my focus was very much on pregnancy and decision making, but a lot of what I learned was related to stigma and discrimination, which is something that I'm sure Alexis will talk about when we're thinking about the purpose of our qualitative research and some of the things that might emerge that may not necessarily relate to the exact purpose, which can be challenging for things like dissertation studies, but I had a really great committee that really understood you're finding new things, and that's okay. So some major quotes related to stigma discrimination. We noticed that there was stigma at multiple levels, thinking about this from a socio-ecological perspective. And Jonathan also, in the conversation about intersectional stigma, I think this also very much relates if we think about stigma as being more of an institutional or structural manifestation that can also, I would say, emerge on an interpersonal level as well. So we're learning more and more about stigma. Our language changes, but women talked about taking prescriptions and needing to go 2 towns over because they were concerned about people running into people that might recognize and disclose their HIV status. So lots of interesting findings from the study. I will not talk about that. I'll share the article, happy to talk about it. But what I really dealt with for many years is understanding some of the unanticipated ethical challenges, and this is where the Institute came in and really helped me to process and provided me with the language and the skills to conceptualize and make sense of what I experienced in the field as a novice researcher. So my IRB protocol was to conduct these interviews specifically in HIV clinics. I had challenges recruiting. So I talked to some clinic staff and they're like, we think there's transportation barriers, so maybe you should revise your IRB protocol. I did that, and I said that I would conduct these interviews in a place that was mutually safe and private for the researcher and participant. I learned from some women that they experienced a lot of stigma within clinics, so they felt uncomfortable talking about their experiences of stigma within clinics, which is of course something that the clinic staff was not aware of. I also learned in going to people's homes, a lot of people were like, great for coming to my home, but we can't do this interview here. I didn't have a ride, so I did a lot of interviews in my car, driving around the corner. Similar to what Celia brought up earlier, I was concerned that people would see me as the person conducting HIV research and recognize my Honda Accord. So all these different instances of potentially disclosing someone's status through presence. So just a few participant preferences. I would like to conduct my interview in your car. I would like you to come to my hospital room to conduct my interview. This was a woman that was pregnant and, admitted early, and she just said she had lots of time on her hands. I also would like for you to come to my home to conduct the interview. So just a few examples. So these are some main, I would say, salient interview locations and salient dilemmas that I experienced. My first car interview, a participant told me that she hadn't disclosed her status, but she still wanted to participate in the study. So then we found an alternative location, which ended up, again, being in my car. A hospital room, the participant said that, I knew that there were sensitive questions, and her partner was actually in the room. I requested that our partner leave the room, and she's like, no, anything that you say in front of my partner and me, you can also say to my partner. So she really expressed that, a lack of stigma in their relationship. So again, it was my imposed perceptions about her HIV status and not feeling comfortable having conversations about reproductive and sexual health. And finally, the first home interview that I did, a person received an eviction notice during the interview. I was not from South Carolina, traveling with a friend. He was like, I'm really concerned about this neighborhood. And when I went to the apartment, I was just a little uncomfortable. There was a dog in the room, just a stench. So all these things that really made me think about, so what's my obligation as a researcher, someone that wants to do health equity and health disparities research, but when you're actually immersed in these environments, what are the implications for respecting participant preference? So I published a paper with Celia and other colleagues where I talked about ethical challenges and lessons learned from qualitative research. Again, this is just an evolution of my early work with women living with HIV, thinking about the lack of participant voice of people burdened by health disparities. Not a lot of literature out there that really reports on lessons learned in these engagements. So this is something that I was saying, Brandon, it's really important that we just do a lot of documentation and note-taking, and memoing, which I actually was able to do to really help us to provide other insight to people doing similar work. When we think about conducting qualitative research, it goes beyond what IRBs might expect. It's important for us to report back to IRBs about our experiences so that they also have that insight. And a lot of Celia's work really focuses on respecting moral agency of participants, also trusting participants' perceptions of what they view as benefits, harms, and also what is justice in research as we're having conversations about incentives and other forms of value to the participants. So this is my perspectives around anti-racist praxis, particularly in public health research. Again, as part of my evolution, my journey to understanding more and more interest in research ethics. And during the pandemic, and I know Shira talked about this the other day, like you're witnessing things and it's like, what can I do? And it's sort of the angry feeling, like all of these articles are talking about populations being vulnerable and vaccine hesitant and blaming Black and brown communities. So I just constructively decided that I would write a paper. My first draft was really horrible. Celia gave me feedback because it was the angry draft. I always say the first draft is the angry draft. So you have to take a step back. Okay, what am I really trying to say? Like remove myself from the actual narrative. And eventually I realized that, even in the pandemic, as it relates to engagement with vaccines and other forms of public health perspectives, it's really important, of course, to center and respect participants' perspectives. They should be included in all phases of the research process. So I was also involved in a lot of grants, RADx, COVID grants, and there were human subjects boards that NIH was requesting, so I was over one, and as a collaborator and also in that process, it's like, okay, so we're still developing these grants without the perspectives of communities who are really affected by COVID-19. And I just started thinking about the importance of these frames that we were using, and a lot of the meetings talking about populations and really these negative frames, again, rooted in scientific racist ideologies. And I was like, this really impacts the questions that we ask, the funding that we receive, the development, the approaches that we even use to answer these questions. So a lot of focus on, of course, individual level behavior. We have to get people to wear masks. We need to get people to use PPE, all of these things, but not really focusing enough on the structural and institutional factors that really perpetuate these individual level disparities. So this paper really highlights that and also documents my interest in research ethics, these frames such as Black race is a risk factor, distrustful media, also reflected in the scientific perspectives and articles, but also in just general media. We saw a lot of this during the pandemic. We saw it before the pandemic, but it also became more evident, and I would say even exacerbated during the pandemic. So these are some things that we think about as experts doing this work, but also the context. And again, not saying this is very dynamic. There are instances where some of this language, I don't want to say is appropriate, but depending on what we're doing. But I'll talk a little bit about reframing. So again, really building on this interest, I was talking to a colleague and we were having a conversation and we're like, let's talk a little bit more about institutional distrust. Although I felt like this was magnified in the literature, again, a lot of articles that were published during the pandemic weren't really thinking about trustworthiness in the COVID-19 pandemic. So again, thinking about shifting the language, how can we become a more trustworthy healthcare system? How can we become a more trustworthy research enterprise? So this article really focuses on that, and again, highlighting that individuals aren't inherently distrustful. We want to really think about these collective experiences across an individual's life course and how they amass, and that these unreconciled injustices, which usually doesn't happen in research or doesn't happen in healthcare, can really influence people's interest and willingness in engaging with us as researchers or really engaging in healthcare generally. So these are some perspectives that we talked about here in this paper. So then I offered counter narratives, the basic suspects, but individuals are not inherently distrustful. We always want to keep that at the forefront. They're not even inherently vulnerable. And I know that there are different perspectives, and there's situational vulnerability. There is cognitive vulnerability, of course, but I'm talking about vulnerability related to systems and structures, socioeconomic status, violence, other forms of social determinants of health that really influence or give rise to vulnerability. So keeping that as the context, keeping that at the forefront, and of course thinking about communities offering unique local and contextual expertise and making sure that they're respected and acknowledged. And this is something that's talked about in the Institute a lot, and I really appreciate this perspective around research ethics and centering participants' voice. So along the way, the American Medical Association, they established a Center for Health Equity led by Dr. Aletha Maybank. So of course, AMA has its history of really perpetuating racism, but more recently has really developed approaches, and this is the reconciliation piece, and acknowledgement that they have to do things differently and they have to do things better. So in that process, they developed a guide to language and narratives. I really like AMA's strategic approach to advance health equity. I think there should be something that's similar in the research enterprise that we have to talk about in terms of how we're advancing health equity in our work. But one of the things that I found very helpful and really appreciate about this particular guide, and there's a resource later that I'll highlight, is that when we think about health equity, it really requires, when we talk about this dismantling, we all have to take a step back. Even as a Black woman, I have to think about what things have I internalized about even the communities that I work with. What are my own biases? What are some things that I take for granted in terms of societal perceptions, imposed racism and discrimination, and thinking about how that translates into our language, the narratives, and the ways that we think. And again, how can we take a step back and think about what are those things that are part of our ethos that need to be reevaluated and interrogated. So they talk about malignant or dominant narratives, which, borrowed from other fields. When we think about these deeply rooted, ingrained, widespread stories, explanations of cultural practices based on lots of different social identities, and of course dominant groups, and this is very dynamic, and when we think about these, and we think about these intersections as well. But what they do really well is talk about these principles and associated terms, and this has actually had a lot of controversy around the development of this guide for many different reasons, but I like to think about the use of avoiding stigmatizing adjectives, and a lot of us have been doing this for some time now, but using under-resourced to describe communities. I like to use minoritized populations instead of saying populations are minority. Again, there are some instances where using minority is important, and I have to, but when we think about it from a structural perspective, people living with HIV, of course, humanizing people, many of us do that, and avoid unintentional blaming. So again, people with limited access to PPE instead of workers who don't use it. So again, there are a lot of different ways that we can think about, again, interrogating our language, figuring out when the use of language is appropriate. Sometimes in our grants, there's just certain language that we have to use. I am hopeful that with NIH's focus on addressing institutional and structural racism, we'll also start to interrogate how populations are described in our grant reviews as well. So changing the questions that we ask, I mean, there's a lot of ways to think about this, but again, how do we treat the consequences of health inequity? How do we act on the root causes of inequality to meet human needs? So these are some really good examples when we think about promoting health equity. And again, it will require to reframe our thinking quite a bit. So I tell my students, I actually had to undo a lot of the learning that about groups from even my PhD program, and I had to study more. I had to read more Black feminist theology because these were not things that necessarily were even taught in my public health program. A lot of times people just say, oh, public health, everyone's so progressive and advanced, and it's not necessarily the case, especially when we get down to what's actually being taught in public health curriculum. So just a bit to think about the field of bioethics. We know that research ethics is a subspecialty of that. I feel like this group, RETI, we're a bit of unicorns. Everyone's not thinking about populations and centering populations' perspectives, especially in the field of bioethics. So we have a really unique purpose and I would say path for making sure that we're really defining what justice is and how bioethics, the field, should be involved in promoting justice broadly. So this is something that I worked on with colleagues recently as a response to an article that talked about a lack of empirical funding for bioethics work, and some of the things that are funded related to technology and related to genomics, but not necessarily focusing on things that really impact the day-to-day experiences of populations. So this is something that, you know, I highlighted more recently. When we think about ethics, sometimes a lot of the focus is on bedside manner, medical dilemmas, and again, very important to think about people that experience these dilemmas. Should I buy food today, or should I pay my rent, or, you know, all of these things that are actually happening with people making decisions because of structural and systemic disparities and violence. So what are certain issues that haven't gained academic visibility and prominence? So thinking about dilemmas related to Black maternal health, and then the need for the bioethics, the field of bioethics, to really look at the composition, the racial and ethnic diversity or lack of diversity in the field, and who's dominating thought, what are the malignant narratives in the field of bioethics, and how can we dismantle those? So I asked the question, the importance of the work that we do. So how can an integrated public health and bioethics lens really be used to advance health equity? And I raised this question more recently. A lot of the feedback that I get about my work is that, oh, well, you don't do a lot of normative work. You know, you're more of a public health scholar versus an ethicist. I think moving to Baylor a year ago, I think I went from being a public health scholar who did health equity work, and now in some circles people are referring to me as a bioethicist. So it's just very interesting in terms of even how my identity is viewed, and thinking about the importance of empirical data and how the empirical kind of camp gets put into more of a research perspective versus a bioethicist. So anyway, I argue that, you know, our empirical work, our approaches can really inform normative frameworks. So even if, you know, I'm not necessarily beginning with normative perspectives, I have used all of my research findings to really ask normative questions now. So that's really the phase that I'm in, writing more thought pieces, because I have a decade of research experience in really using those insights, allowing us to combine these lenses to address gaps in bioethics scholarship through more empirical approaches. So I really think about this as an iterative process to promoting health equity. So when I think about advancing health equity, I can't leave out the importance, and we talked a little bit about that, of mentorship and sponsorship in the field of bioethics. And I bring this up because here we're at the Institute, and, you know, all of us are in a position and will eventually be in a position to really advocate for other populations, students, training. Celia has done a wonderful job of promoting our work. Rima is wonderful about promoting our articles, and all of these things are really important when we think about being able to maintain and sustain ourselves as academics are in a lot of different positions. So I use sponsorship here because I think it's a really important distinction between sponsorship and mentorship, and really using power, leveraging your reputation, your networks, especially for people that may not have access to these networks. So this is an important part of advancing health equity, I argue. So I did a presentation early in the pandemic. Celia, they had a series, and I talked a little bit about this. And one example was an invite to NIMHD in 2018. I can't believe it's been that long. And I presented with Alana, Celia, and Nicole Overstreet. Alana, I know, will be here soon to talk about her work. And it was a really amazing perspective around thinking about ethics and health disparities. Again, provided opportunities for us, visibility for us. This is especially important for women and scholars of color when we think about using sponsorship as a way to show institutions like, oh, wow, these people are doing these things outside of the institution. Sometimes it gives you the space. Institutions will give you a second look, although they should certainly value you like for doing the internal work, but it does provide a bit of leverage. And I would say that these are examples that have really helped to enhance and advance my career. And again, something that we can all continue to do when we think about giving back and paying for it. So highlighting that mentorship practices should be truly altruistic and not necessarily transactional. So I liked Shira's point of a mentorship contract. Of course, highlighting what those expectations are, but making sure that our trainees are getting what they need to advance their careers. So I'll just end by saying that bioethicists have a moral and professional obligation to really center racial, ethnic populations, to strengthen discussions of racism and bioethics, which is especially being elevated right now. And I'll highlight a recent special report that I led with other colleagues on anti-Black racism in the field of bioethics and healthcare generally, but lots of articles around health equity and why health equity has to be a focus, why we should promote health equity, why health equity should be elevated in the field of bioethics. So these are some examples of programs that I've been involved in, for instance, really developing training programs to advance careers in health equity. A lot of us have had to be really creative. For people that have wanted to do empirical ethics work, aside from the Institute, I've had opportunities, created opportunities through Society of Family Planning to talk about reproductive ethics and their interest in work around reproductive ethics. So again, I'm happy at some point if anyone's interested in talking about any of these training programs. But the piece I really want to highlight is that a lot of these programs, sometimes, and Celia, we talked about that briefly, calling programs minority internships or minority training programs tends to really diminish the value of the program. And I had experiences actually with the Research Ethics Training Institute. When I received it at UIC, one of my mentors said, oh, is that a minority opportunity? And I was like, actually, it's not. So I think we have to be sensitive, even in terms of what we call programs or the purpose of programs, because unfortunately that will be the perception when there are programs that only have scholars of color. In some ways it's unavoidable, but I think the Sadler Scholars Program, I highlight that at Hastings Center because the students, PhD, primarily Black and brown students, they liked that it was called the Sadler Scholars and someone's last name versus the minority program for PhD students. Again, being very sensitive to those things because unfortunately programs will not get the same level of prestige if they're viewed as minority only. So I'll highlight some training. My students, we talk a lot about health equity and how they can use health equity in their careers and medicine and public health. My first student, Javonta Tribbett, she's actually still at UAB and really interested in the integration between public health and bioethics. All of these students have an interest in bioethics, and again, I view them as the next generation of bioethicists. And in conversations, actually working with my student Javonta, I'm like, well, what do you think about bioethics and how the field can really advance health equity? We're having these conversations. And she commented, traditionally, bioethics has focused on justice from a limited lens as a result of the field's limited worldview and framework. Social awareness is needed to expand the reach of bioethics, meaning how can one promote social justice without an awareness of social justice issues? Those trained in public health are equipped with the theoretical and practical tools and attuned to the needs of marginalized communities to address social determinants of health and promote health equity. Social justice requires multifaceted and cross-disciplinary collaboration and approaches. And I really appreciated that perspective from someone that has been working with me for some time now and really interested in the integration. I think many of us have had to carve out our own paths. There aren't a lot of programs that are integrated public health and bioethics more now than before over the past decade, but it's especially important to continue to do this work and find ways to fund this work so that people can receive interdisciplinary training. So I will end there, and here are some references. These are all the resources, the special report. I included that link in the AMA resources that have been really helpful in my thinking about these issues. Thank you for having me.